Okay, so why don't we go ahead and get started. So we're going to talk about laparoscopic cholecystectomy today. Can we turn the lights up just a little bit so I don't fall asleep down here? Just a little bit, thanks. Yeah, much better. Now I can see everyone. Anybody falls asleep, we'll call you out. So anyway, complications of laparoscopic cholecystectomy and what interventional radiologists can do about them. So it'll be a little bit of an interventional radiology talk, but there'll also be a fair amount about imaging and other things. So I think pretty much everybody here nowadays knows about laparoscopic cholecystectomy. Without a doubt, it's the standard of care for symptomatic gallstones. It's rare for someone to get an open cholecystectomy these days. It was really one of the very first minimally invasive procedures, surgical procedures. I don't know if anybody in the room's had a lap chole, but you're usually in and out of the hospital, sometimes even the same day, maybe with an overnight stay. Return to work in 7 to 10 days, which is quite remarkable when you think about an open cholecystectomy where people really were out of work for 4 to 6 to 8 weeks. And the hallmark of laparoscopic cholecystectomy, as we'll talk about, is the fact that you have very little postoperative pain. So that's a really very remarkable thing to think about when you're having your gallbladder taken out. So I'm sure most of you have rotated on surgery. If you haven't, you should have. And you've been involved, I'm sure, in laparoscopic procedures, laparoscopic cholecystectomy, and have a little bit of an awareness of what the technique is. I'm not going to go over the surgical technique, but I will say that as in many minimally invasive procedures, the learning curve is very steep. So particularly at the beginning of a surgeon's experience, and particularly if the surgeon doesn't have experience in a training program, there's a significant risk of complications in the first 50 cases. And that's been shown over and over again in the surgical literature, and was probably really one of the first places people started to talk in the surgical literature about learning curves. In interventional radiology, we know about that for a long time. Bile duct injuries by far are the most common injury, and that's what we're going to be focusing on today. But my words of advice, and people frequently ask me for a referral to a surgeon for a lap chole, and I will just tell you over and over again, you want to go to a surgeon who's done this procedure a couple hundred times, because while it's a wonderful technique, the complications can be really awful. So just like anything else, any procedural thing, before you get started, you carefully think out all the angles. You want to be sure you know what you're doing. Of course, you've done it 1,000 times or maybe just a couple times. The procedure, as all of us who do procedures know, they just come naturally to us. It doesn't take any hard work. You know what you're doing. It's what you've always been trained to do. Nothing could possibly go wrong. But yet, we know stuff does go wrong. And I think it's really important to look carefully at your complications. We try to do that, and that's what we're going to be talking about today is complications. And we sure see a lot of complications here with laparoscopic cholecystectomy, primarily because that's we're a tertiary referral center. We have subspecialty expertise in that. There's surgeons who have expertise. There's interventional radiologists that have expertise. And so it's really an important part of our practice. Bile duct injuries, again, this is well documented in the surgical literature. Bile duct injuries with laparoscopic cholecystectomy are 3 to 4 times more common. I remember before people started doing lap choles, we would occasionally see bile duct injuries with open cholecystectomy, but they were really unusual. Nowadays, we almost always have a patient on our service that we're managing either due to a complication or long-term issues with complications. So by far, the most common cause of serious bile duct injuries, and again, this has been studied in the surgical literature very carefully, is misidentification of the common bile duct. And it sounds hard to believe, but it is a frequent occurrence that the common bile duct is misidentified as the cystic duct. And so, you're looking at things, and we'll talk a little bit more about the field of view and things, but instead of clipping the cystic duct right here and taking it out, the common bile duct is taken out as thinking it's a piece of the cystic duct, and that results in catastrophic injuries. So, we all sort of think of normal anatomy, maybe back to the days when we did cadaver dissections ourselves, and you think everything is nice and smooth in there and it's all easily identifiable, but it's actually Not the case when the gallbladder is inflamed. And we more and more these days we're putting cholecystostomy tubes in patients who have acute or chronic inflammation in order to let that settle down to try and make the laparoscopic cholecystectomy procedure easier. But you can see if the gallbladder is large and swollen like this and up adherent against the common bile duct, or if there's a large stone impacted in the neck of the gallbladder that kind of gets everything to be tied together, or if there's even a very long cystic duct, it can be very difficult to identify the anatomy laparoscopically and end up injuring the common bile duct. Another important factor is aberrant anatomy. And so the biliary anatomy, just like the portal vein and the hepatic artery anatomy, is so frequently aberrant, is so frequently away from the typical standard that you really can't call it aberrant. There's so many variations, and the bile duct anatomy has the same sort of variations as the portal vein anatomy, and it's mostly the right posterior duct that has aberrant anatomy. So here's what you think of when you think of sort of quote-unquote normal anatomy, whether you're thinking about the bile duct or the portal vein. You have a main right portal vein, or main bile duct, main left bile duct, anterior, posterior. These are mislabeled. This should be anterior, and that should be posterior. Very, very commonly, that posterior duct can insert over on the left duct, and also very commonly, that posterior duct can insert down low on the common bile duct. And so unusual, or what you want to call it, it's actually usual anatomy, is actually not as frequent as people might assume.